Hello everyone, the next part of the lecture is going to focus on antipsychotic medications, and Vicky's very helpfully given you a bit of an overview into kind of what we need to think about when we're providing medication for the consumers that we work with. And this short lecture will be focusing specifically on antipsychotic medications and some of their side effects. So the typical or traditional antipsychotic medications have been an important treatment for psychotic disorders since their discovery in the 1950s. They revolutionized the treatment of mental illness, and they were the first choice of treatment for most psychotic disorders for many, many years. They're indicated for use in treatment of acute and chronic psychosis, delusional disorder, severe depression where psychotic symptoms are present, and schizophrenia and schizoaffective disorders are kind of the most common indications for use. These type of medications do need to be taken for a few weeks before any clinical improvement seen, and the treatment can often go on for many years. Like lots of things in the mental health sphere, the exact mechanism of action of the antipsychotic medications remains still a bit unknown. However, we do know that they work by antagonizing or blocking the dopamine D2 receptor, and there's evidence in schizophrenia that there's highly altered levels of dopamine activity. And it's thought that this kind of activation of dopamine causes the positive symptoms of psychosis. But there are limitations to the dopamine theory. It doesn't really explain the cognitive deficits, doesn't kind of look at any other pathways or anything. So the newer antipsychotics, the atypicals, they act on both serotonin and dopamine. So they have some less EPSE side effects, and we're going to talk about them a little bit later in the lecture. The Royal Australian and New Zealand College of Psychiatrists have developed some clinical practice guidelines around the management of schizophrenia and related disorders. And these guidelines now reflect a more holistic approach to treatment. So it kind of addresses all aspects of the care of people with schizophrenia and the related disorders, not merely a correct diagnosis and symptom relief, but it also thinks about optimal recovery of social function. So then there is an emphasis in these guidelines, and I guess in our treatment philosophies, on early intervention, physical health, psychosocial treatments, cultural considerations, and improving vocational outcomes. Pat Deegan, who's a person with lived experience, who you may have seen a video of earlier in the semester, she has a website called Common Ground, which helps consumers talk to their health professionals about medication. And she says most medication management decisions in psychiatry involve medications with similar efficacy profiles, but complex risk-benefit trade-offs. And so that's kind of why decisions about psychiatric medications are not just medical decisions, they're also personal decisions that will impact on physical health and also quality of life. And so as nurses working with the consumers, these are things that we really need to keep in mind as well. Antipsychotic medication comes in a variety of forms, and you'll see this in action on your clinical placements. So tablets are the most commonly used, obviously. Some of the drugs come in a syrup form, which may be slightly easier administration. Some come in wafer form, which kind of dissolve very, very quickly on the tongue. So if there's concerns that consumers might be maybe spitting their medication out or putting it under their tongue or something, this can be a way around that. There's also intramuscular injection forms of the medication. Sometimes people are on fortnightly depots or monthly depots, depending on which drug they're on. So the long-acting IMI, antipsychotic medications, it is quite a helpful treatment option for people whose adherence to oral medication is poor. And so for some people, the use of the long-acting injections is a convenient option to overcome the need to take the medications every day and also to maintain remission of their symptoms. But I guess we do need to always consider a non-judgmental approach when we're talking to consumers about their medication. Great. So as I mentioned at the kind of beginning, there's typical or first generation antipsychotics and also atypical or second generation antipsychotics. So this slide talks about the typical or first generation antipsychotics. These have quite good effect for reducing and eliminating positive symptoms, but they do have a pretty poor side effect profile. And this is a big cause of concern because of the effect on people's quality of life and the link with non-adherence and also the high risk for EPSE. They're sometimes used to treat agitation in addition to regular antipsychotics because they can be quite sedating, for example, chlorpromazine. However, more commonly on the wards now, when consumers are agitated, they might be prescribed a benzodiazepine for this and for the kind of settling effect. Because there is obviously a risk with people being on a number of different antipsychotic medications. It kind of increases the risks of side effects. While these medications aren't commonly used in tablet form anymore, they are still seen in their long-acting injectable form. These are some of the more commonly used typical antipsychotics. And there are a number of side effects. So quite common side effects is restlessness. People develop tremors, muscle stiffness, constipation, some weight gain, EPSEs, and neuroleptic malignant syndrome. And we're going to go through the side effects in a bit more detail in a sec. So the atypicals, or the second generation antipsychotics, are newer, and their efficacy is similar to the typical antipsychotics in reducing those positive symptoms. They do have a slightly better side effect profile. There's less neurological side effects, but there are other side effects, and kind of the main concern is metabolic issues, which we'll talk about in a minute. These are usually now the treatment of choice for psychotic symptoms. And I said a second ago, the efficacy is similar to the oldest antipsychotics on the positive symptoms, but they do seem to be a bit more effective in reducing the negative symptoms of psychosis. So these are some of the commonly seen atypical antipsychotics, and hopefully you'll get to see some of these when you're on your placement. See how they're used. There's also injectable atypical antipsychotics, which we can use as well. So the relatively common side effects are sedation, weight gain, dizziness, metabolic syndrome, which is a huge problem as mentioned, raised prolactin levels. There is some risk of EPSE when these drugs are used at higher doses, and there's also potential cardiac problems as well. So just to mention clozapine, which is an atypical antipsychotic that's far more effective than any of the other antipsychotics in kind of reducing psychotic symptoms, but it has potentially very severe side effects that mean that its use is limited to people with treatment-resistant schizophrenia. And that means people that have been trialled on at least 2 other antipsychotic medications with no benefits to their symptoms. So then they'll be trialled on clozapine. There's lots of side effects that come along with clozapine, and pretty common people to have an increased appetite, feel quite sedated, have lots and lots of saliva, low blood pressure and dizziness. And then there's the quite serious side effects of agranulocytosis, myocarditis, seizures, hepatotoxicity, diabetes, severe constipation, and potential bowel obstruction. So there are quite clear clinical protocols that have been established, and people on clozapine have mandated blood monitoring. So when they first start the medication, it's weekly for the first 18 weeks, and then that changes to every 4 weeks forever when they're on the drug. And this kind of monitors the white blood cell count and the neutrophil count, and make sure it's within a particular range, and if it's not, the drug must be ceased. There's also issues with people suddenly stopping smoking cigarettes. Their dose might need to be adjusted as well, but I'll mention that in a sec too. So these are some of the side effects that I briefly mentioned before. The EPSEs are caused by the dopamine antagonist, so more common with the older antipsychotics. And the extrapyramidal system is part of the motor system involved in coordination of movement. So these present with kind of movement disorders. We kind of think about 4 EPSEs. One of them is the Parkinsonian symptoms. So consumers might present with rigidity, a mask-like face, shuffling gait, tremor, difficulty speaking. The side effects kind of appear like the consumer has Parkinson's disease. So these symptoms can occur quite quickly when people start on medication, and we can manage it by administering an anticholinergic medication. Most commonly we use benzotropine. Akathisia is another symptom that's very, very annoying and horrible for consumers. And it does have quite a big impact on people's mental state because it's so frustrating. So people kind of have this restlessness, they can't sit still, leg aches. There's also so an actual restlessness, but also a subjective sense of restlessness kind of internally too. And it's managed by reducing the dose, changing medication, or a low dose of propranolol as well, which is a beta blocker. Another of the EPSEs is acute dystonia, which is acute and painful muscle spasms. Results in facial grimacing, torticollis, ocular gyrate crisis, and this can last from minutes to hours. It can come on very suddenly and it's quite scary. This usually occurs pretty early in starting the medication, and it's also managed by administration of benzotropine. Sometimes that might need to be IMI or IV if it's quite serious. And I remember when I worked at Redfern, one of our clients was feeling quite distressed, and he was on risperidone, which is one of the newer antipsychotics. But because he was feeling so kind of agitated and not great, he just took more and more and more, like kept taking a small amount over and over again, and he ended up with the side effect of ocular gyrate crisis, which we sometimes call the look-up. So you can Google it. People's eyes go right up. And he came into the centre and needed IMI benzotropine, which did work quite quickly, but it was very distressing for him, and it's kind of distressing to look at as well. So the final one is tardive dyskinesia, which is a persistent, exaggerated and involuntary movements of the mouth, neck, tongue, limbs, and this can persist over time. So sometimes this is irreversible actually, and it's not uncommon in elderly consumers that we work with because they might have been on some of these medications for many, many years. So there's kind of proposed theory that there might be a build-up of the drug in their brain, and that's why it can't, that's why even if they cease the medication, it might not be reversible. In the reference section at the end of the lecture, there's a link to a YouTube video that shows some of the EPSEs and how we kind of check for them. Another side effect, which is rare but potentially life-threatening, is called neuroleptic malignant syndrome, and it needs to be kind of managed by immediately discontinuing the medication and monitoring, and usually requires immediate medical intervention in a general hospital if it's suspected. So both the typical and atypical antipsychotics can cause neuroleptic malignant syndrome. Another side effect, much more commonly from the atypical, the newer antipsychotics, is metabolic syndrome. And this is a very serious issue actually. The weight gain for consumers usually occurs within the first 4 to 12 weeks of treatment, and it's associated with abdominal obesity and enhanced adiposity. So it is linked with increased morbidity and mortality as well. And metabolic syndrome is made up by a cluster of abnormalities which are listed there. And, you know, when those things are experienced together, there's an increased risk of diabetes and cardiovascular disease and things like that. It's not fully understood why these drugs cause the weight gain or changes in the metabolic system. But we do need to work with consumers around this, you know, around exercise, linking people into GP clinics. Lots of mental health services now have metabolic clinics as well. It requires kind of education for the family and consumer and nurses too. This slide just has a list of some of the medications and the kind of cardiovascular risk factors associated with them. I just wanted to mention treatment of first episode psychosis. I guess the kind of overall theme is start with low medication and like go slowly. Normally we start with an atypical antipsychotic, one of the ones listed there, but also very important for first episode, like with anyone with a psychotic illness, is to think about those non-pharmacological approaches as well. And some research says that the top 5 goals of young people with first episode psychosis are those things listed there. And so, you know, those goals highlight the importance of us providing psychosocial interventions as well. And it's also very important that we be working with the family of the person with first episode psychosis. I also just wanted to mention smoking and antipsychotic medication. Excuse me, smoking might increase the metabolism of some antipsychotic medications, which means that they don't work as effectively. So people need to be on higher doses if they're smoking lots of cigarettes to get the same effect. So we do need to think about that if someone's going to suddenly stop smoking, they're going to be on way too much medication. So we kind of need to think about that when we work with our consumers as well and provide education. Just some general nursing considerations when thinking about working with consumers who are on antipsychotic medications. Again, like we harp on about every week, the therapeutic relationship is the cornerstone for effective treatment. We need to be providing information and education on medication and potential adverse effects. We need to discuss with people their preference for what medication they like best, which they've tried, etc. We need to monitor our consumers for the adverse effects. It's very important that we focus on psychosocial interventions, talk to people about their smoking status, and also support smoking cessation. It's important that we liaise with GPs and help link our consumers into GPs for some of those physical health issues, and also advocate for the consumers that we're working with when they see their psychiatrist for medication reviews. And I've just popped the link there for Pat Deegan's website, and she has information there for consumers so that they can kind of feel ready to work with their doctor around their medication. There's just some references, and you can access the links at your leisure.